All right, guys, so yeah, this video is going to be about the Australian exam. And I had a chance to kind of do a little bit of research online. I was trying to find some type of outline or something that kind of guide me as far as where to take it. And I found this online. And again, it's performance by the patient group for scored items, AMC, the Australian Medical Council, MCQ examination. So when I look at this, I know, I'm reading like it's 150 questions, I believe. And, I guess, down here it says 120 on something. But anyways, I was told it's 150. But what I'm going to focus on today is this population health and ethics section. And, gosh, I wish I could do the mental health piece too, because look at this. If you combine 12.5% of the scored items and 12.5 of the scored items, that's 25%. 25% of your exam are population health and mental health. I mean, that's, those are like gimmies, right? So, I was kind of calculating this just to maybe build some confidence in people, but if you have 150 questions and, if you took, 25% of those, and gosh, I should have done the math before I did this, but you're looking at 37.5 questions, or 38 questions are going to be roughly in this section here, which should be the easiest section. So, even if you missed, the way I was looking at it, if you missed even only 10% of those questions, that would leave you enough on the remainder of this exam to where all you got to do is basically, by my calculation, is get 2 out of every 3, 2 out of 3. So you got to run 66%. So the way I look at it and try to get confident when I take an exam is I know I'm gonna do very well in this section. If I allow myself to only miss 10% of these, worst case scenario, then I just, for the remainder of the test, for every 3 questions, I just got to go on a 2 out of 3 winning streak. And therefore, I take 3 questions at a time, do my best. If I'm getting 2 out of every 3, I'm feeling confident that I'm on the right track to pass. So anyways, that's how I would approach it. Now, back to why we're even here. Today, I'm going to review some stuff on this exam and mainly focus on a lot of things through here, not only the biostats piece, but when I look at this, they really kind of emphasize certain areas here. They talk about surveillance, vaccination programs, population education, epidemiology, some legislation piece, population health concepts. So what I did try to do is tailor the first part of this toward these. I mean, because it's not really detailed. They're not saying, oh, you got a new sensitivity. They're actually going to these concepts here. So I focus in on that. As well as some of these screening activities, okay? So that's going to be our focus. I got this offline, so hopefully we're over the target. And then from other stuff, when we get there, pulling off the Australian Commission on Safety, But anyways, when it comes to informed consent and stuff. So anyways, a lot of this, I'm trying to make it as research-based as I can. But let's get started. Let's quit wasting time and let's get you guys prepared for this Australian exam. So here we go. This first one says, a campaign against drinking and driving would be an example of which of the following preventative stages? Is it A, primordial? Is it B, primary prevention? C, secondary prevention? D, tertiary prevention? E, quaternary prevention? So when I looked all this up, here's how I want you to go about it. When it comes to primordial, I want you to think government and laws, okay? Government and laws, meaning at the very, very front end, the government's going to step in, do something for the whole population to implement change. And we'll have some questions about some examples on this in a second. When it comes to primary prevention, this is going to be where they're really trying to target at-risk groups, okay? At-risk groups. And again, whole population for primordial. Primary prevention, at-risk groups. The goal is trying to limit the exposure, and it'll all come together here, guys. I'm just kind of being boring right now. And then this is more of a public health action stuff. But here's what I want to the key words. Anytime you see the word counseling program or educational program, you better be jumping all over this primary prevention, okay? Now, secondary prevention. this secondary and tertiary prevention, I want you to think these guys have the disease. Now, secondary prevention don't quite know it yet. So this is going to be in, you want to detect things early. So this is anytime you see screening, okay? When you see the word screening, I want you to think secondary prevention. And then tertiary prevention, they have disease. They're kind of aware of it at this point. So the goal is these people are recovering, but you want to modify the risk. So we should have better, the key is here, better follow-up cares, okay? So far, what have we learned? Primordial, we get everything at the government level, okay? Affects the whole population, implement laws. Primary prevention, there's no disease yet, and so this is at-risk groups, limit exposure, whenever you see counseling or educational programs. Secondary prevention, now they got the disease, but we're going to try to detect it earlier, something like a pap smear, okay, or colorectal kind of exams. Tertiary prevention, now they're in the recovery, okay? We want to modify the risk, so better follow-up cares. And this quaternary prevention, essentially this is saying that too much intervention can be bad, okay? It can be bad. And again, guys, I'm focusing in on this because that one kind of outline mentioned there, it's all about, there's a lot of stuff that focuses on the screening. So let's think about this. Where are we at? A campaign against drinking and driving would be an example of which of the following preventative strategies. Which one has education or a campaign or counseling? It's going to be, correct answer is going to be B, primary prevention. Okay, simple as that, guys. But you just got to know from top to bottom, primordial and government. Primary is going to be counseling or education or a campaign. You can think of it like that. And then secondary, now they got the disease, detected early. Tertiary, it's going to be in recovery, modify risk, better follow-up cares. And then quaternary, too much intervention can be bad. Okay? So this one says, implementation of multidisciplinary clinics is an example of which of the following preventative stages. Okay, so think about this. We talked about primordial is what? Government laws. Primary, no disease yet. Secondary, there's disease. Tertiary, disease. And then quaternary, too much intervention can be bad. Okay, primary prevention, campaign, education. Secondary prevention, we got to do some screening to catch it early. Tertiary, we're trying to do better follow-up cares. So if I'm going to implement multidisciplinary clinics, if I'm going to do multidisciplinary clinics, where do you think that falls in this? Who would go to a multidisciplinary clinic as opposed to just a clinic, right? So what happens in a multidisciplinary clinic? You might have a primary care provider, but in that clinic, you might also have what? You might also have specialists. You might have a cardiologist. You might have a psychiatrist. So with that being said, when the guy comes in to the primary care and then goes to that clinic for a specialty care, he must have a condition and he is aware of it, right? So in this situation, getting referred to a cardiologist or a psychiatrist at a multidisciplinary clinic would be an example of what? Correct answer is D, tertiary prevention. So again, primordial prevention, government laws. Primary prevention, there's no disease yet. It could be a campaign, education. Secondary prevention, it's going to be at the community level. We're going to do something to screen, to prevent it from that perspective. Tertiary prevention is going to be examples like better follow-up care, multidisciplinary clinics, and then quaternary again, too much intervention can be bad. Okay, so let's look at this now. Hopefully it'll fit on the screen here because I made these in shorts. Now guys, all these questions, if you go on to my YouTube channel or whatnot, Randy Neal, heck, you're watching on it right now. So I'm going to make all these into the shorts so you can review them very quickly. There's the mental health, there's biostats, it's all on there. Just go to the short video playlist and you can review each one. It has to be a minute or less to get on there, so it's very, 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 very quick. Well, let's run through these. It says, Educational campaign. Educational campaign. I mean, what are you jumping on right now? You better be jumping on what? You better be primary. But an educational campaign on safer sex practices is an example of which the preventative stages. And again, laws, primordial. Campaign, education, primary. Secondary, you better be doing some screenings. Tertiary, better follow-up care. Quaternary, too much is a bad thing. This one says, follow-up exam to determine if reoccurrence of colorectal cancer is an example of which the following preventative stages, or I should say better follow-up exam to determine if reoccurrence. So it already happened, right? We already know they have disease. Now, just going down through this, again, this is so much on the front end, government laws. This one says too much intervention is bad. Primary says, okay, there's no disease present. Secondary and tertiary, I'm thinking disease present. This one's more screening, okay? This one's better follow-up care. So if you're doing something to determine if the reoccurrence has happened, that's going to be an example of better follow-up care. So the correct answer in this situation is going to be D, tertiary prevention. And just secondary would be where a pap smear would come in. Now you might say, well, wait a second. How come that's not primary prevention? Well, in a pap smear, you're not, it doesn't directly prevent the disease. It's a screening tool, okay? It's a screening tool, and that's why it falls in secondary. But in this situation, recurrence, think tertiary prevention, answer choice D. A law banning alcohol would be an example of which of the following preventative stages. Now, this is a law. Now, again, where's that going to be? That's going to be at the governmental level, right? It affects everyone. Answer choice is going to be A. Again, primary, no disease. Secondary, disease. Tertiary, disease. And quaternary, too much is a bad thing. But when it's a law, it's going to affect everyone. You're thinking primordial prevention. Putting in safe sidewalks in an urban neighborhood is an example of which of the following preventative stages. Is it A, primordial prevention, B, primary, C, secondary, D, tertiary, E, quaternary? You're thinking putting in safe sidewalks. Putting in safe sidewalks. Well, what is that going to do? Well, does it mention anything about having the disease? No. So we can eliminate these guys, right? So, and again, primordial prevention, government laws, it would target, primordial kind of targets the underlying stage, okay, of natural disease. So, putting in safe sidewalks is going to happen at what level? More of the governmental level, right? More of the governmental. So it's going to be answer choice A. And you say, well, how does that really work? What am I doing here? If I'm going to impact, metabolic syndrome or something. Well, it targets the underlying stage. So what's that going to happen? If they're going to put in sidewalks, you're going to theoretically increase physical activity, which would hopefully thereby decrease obesity. And that would have an impact on everyone, okay? Primary prevention focuses on the at-risk, okay? That would be, what's an example? Immunizations, okay? If you said immunizations, that's a primary prevention. It's the targeting the at-risk. The secondary prevention, early detection, okay? Example, like we talked about, pap smear. Tertiary prevention. This is going to be better follow-up cares. You could have when someone goes to rehab, okay? Those are examples of tertiary prevention. And then quaternary, again, when medical intervention may cause more harm than good. Putting in sidewalks, A, primordial, okay? Now, guys, it's very repetitious, but again, sometimes that's just the best way to kind of reinforce this stuff. To as many examples as you can. I don't want you to be on the exam and see something for the first time. But again, this is essentially, okay, that's essentially straight from what they tell you that they're kind of looking for, right? Screening activities, surveillance, population level education, epidemiology, it just kind of resonates with that type of question. Now, this says a 52-year-old female enters the clinic with complaints of headache. Immediately, the staff approach her and show her the blood pressure cuff. She then holds out her arm without saying a word. Okay? This is an example of which of the following? Is it A, informed consent, B, legal capacity, C, implied consent, or D, malpractice? Okay, you're like, where did I get this from, right? Well, it was in that one little article that I had done. So, in a nutshell, yeah, they want you to know stuff about capacity and consent. Now, informed consent, it basically, it's a person's decision. It's a person's decision. It's given voluntarily. Okay. Now, it's given voluntarily to agree. Their informed consent is to agree to the treatment. Now, the Australian Charter of Healthcare Rights, the Australian Charter for Healthcare Rights requires all hospitals and all day centers to have informed consent. Okay, that's a no-brainer. Okay, there is a thing called financial consent, but that's totally different. So you gotta have this informed consent. Now, there's two things I want you to, but now this lady right here isn't informed consent, right? This is more when she's not saying a word because she hasn't been informed, right? She hasn't demonstrated capacity. Because, yes, they might be just checking blood pressures, but, there's no, like, she hasn't been informed of the risks, benefits, alternatives. Because when it comes to capacity, you need to demonstrate what? You better demonstrate an understanding, an understanding of, say, your disease or whatnot. You better appreciate, and these are key words, like when I do psych consults on capacity, I use these in my terminology. The patient understands their diagnosis. They appreciate the risks, benefits of treatment, or the refusal of treatment, including up to death. So they need to be to understand. They better appreciate the benefits, risks. Their reasoning for their decision needs to be sound, right? It's okay to refuse. You have the right everywhere, even in Australia, to refuse treatment if you meet these, there's actually 4 standards to have capacity. Do you understand your diagnosis? Do you appreciate the consequences that you might die if you don't get this treatment per se? And is that sound? Is that a sound reasoning? Well, I don't, they might say my uncle went through this treatment and he was bedridden and it only saved his life for an extra 2 months. Okay, well, that's relatively sound reasoning to me. So they might refuse. And then it's an expression of choice. They got to have choice in that. It's expression of choice. And sometimes I always add in that it's also a long-held value of theirs. And sometimes, we'll call families and say, is this how they always felt? But an expression of choice. Now, if you have these 4 elements, you can have capacity to give informed consent. Now, there's a couple things that apparently in Australia that when I was looking at this, just to be familiar with, okay? There's this thing, there's this common law doctrine of necessity, okay? Now, basically, this doctrine of necessity, it is relevant. And so basically, the treatment is not that if decision-making capacity, as they say, if decision-making capacity was not present, that, it's within that scope, or, you're not going to get raked over the coals if they don't have decision-making capacity, was not present, and someone's in imminent danger to where intervention could save them, that falls under the common law doctrine of necessity, okay? Now, there's this thing called the another common law thing, duty of care, okay? And duty of care essentially says there's a legal obligation, a duty, okay, by the healthcare provider is to inform. This is, it's your duty to inform the patients of the benefits, the risks, the consequences of treatment, okay? And that you don't force cares, okay? And I know we don't do that, but again, it's got to be written down so no one does it. So again, common law doctrine of necessity is, basically you don't intervene in the patient's wishes. Like if you know, and plus if you know something, if you knew their wishes ahead of time, if they're, DNR or something, you don't go outside of that. But also if there's, to save someone's life imminently, also kind of is under that. So again, and the duty of care is, is to make sure that you inform the patient. Okay. Now, I saw a lot of rules and laws when I was researching this, but these two things fall under all Australian jurisdictions. A lot of the other ones were always implying that it's different from where you're at in the country. So, I just don't see people testing you on something that maybe did in different parts of the country. But when it comes to all jurisdictions, this common law doctrine of necessity and the duty of care, you got to be familiar with that. So in this lady, the fact that you don't have to always have informed consent in certain situations, and again, there's a scale of moving down in terms of how severe or but checking someone's blood pressure is kind of low on that scale. And then she initiated her arm out, so that is what is considered implied consent. Okay, so informed consent, you better benefits, risks, consequences, alternatives. Make sure they give a verbal understanding back. That's just mine, that they don't write that down here, anything in Australia. And then legal capacity, it's an understanding and appreciation or reasoning and expression of choice. But in this situation, for this answer, again, it's going to be implied consent. And again, where did I get this from? Before I prepared on this, I was looking at the Australian Commission of Safety and Quality, and they, they just talked about all this stuff in here. And, interesting. You got to be familiar with it. But I think sometimes you're just kind of more common sense. But again, I don't want you to be on the exam seeing it for the first time. All right. Now, this one. It says, using medications treating PTSD in war veterans would have an expected effect size reflective of which of the following values. Now, I didn't talk about this in much of my other videos, so that's why I'm putting it in here just for you guys. Because you got to be familiar with effect size, the term effect size. Because sometimes, well, I shouldn't say sometimes, because significance doesn't always mean relevance, okay? Because you're going to have to be familiar with, p-values, right? What's a good p-value? Well, a good p-value, just by kind of a gold standard, is less than 0.5. What does that mean? It basically means that it is less than 5% likely the result occurred by what? Occurred by chance. So we accept anything, or we like anything, less than 0.005. I mean, or 0.05, excuse me. And then we have these things called confidence intervals, right? Now, typically, accepted confidence interval is like 95% threshold, okay? And so that means that within 95% chance that things are going to fall within this range. And you'll see a confidence interval, they usually label it like confidence interval 1.1 to 1.8 or something to that effect, right? And then basically I look at that and say, okay, whatever if it was a new medication, that it has a 1.1 to 1.8 times greater likelihood of seeing that result, okay? And I don't want my confidence interval ever, I don't like it. I always shoot down the results where the confidence interval crosses 1. And you say, well, why is that? Because in this study, if it crosses 1, that means the drug and the placebo at some point were the same. There was no difference. It was not greater, not less. It was the same. So what good is that to me? Okay, in that study, other than to tell me it doesn't really work any better than the placebo per se. So again, now the purpose of me even saying this is because sometimes you'll have a nice confidence interval that looks good on paper. You'll have a nice p-value, but then you won't really have you gotta have an understanding of what the effect size is, because that's gonna show you the relevance. Okay, so you gotta have a familiarity with this. And so I'd put effect size here. And then down here, you have the number needed to treat, number needed to harm. You got to be familiar with that, right? Number needed to treat. How many people do I need to treat to have an impact on one patient? So in theory, I want this to be, number needed to treat to be a low number, low single digits, right? For a medication, I'd be nice. Okay, I got to treat one, I got to treat 2, maybe 3 people to have an effect in one. Okay, that's the number needed to treat. I like low numbers for that. So goes back to the effect size. Significance doesn't always mean relevance. And an example of that would be something like this. If the test or the gold standard, okay, if the gold standard said that 10 out of 500 people got better, okay, and you're like, all right, well, that's the gold standard. So now that I do my test, this new test said, oh, 15 out of 500 people got better. Now, statistically, it may look all nice and neat, right? Heck, you had a 50% increase on this new medication. But if this is like a new medication, for something like just nausea or something simple, is that difference really going to have an impact in your practice? Based on this, you'd say no. I mean, come on, like it's only a small difference and there's 500 people and only a few got better. I mean, it's way down there. Now, statistically, it looks good, but the relevance is not good. That's where effect size comes in. So let's look at this. And really, all you got to know in effect size, guys, just to break it down even more simple, 0 to 1. 0 to 1. Does it work? Does it not work? Does it work at 1? So greater than 0.9, this is something like stimulants, okay? Stimulants, methylphenidate, dextroamphetamine, something you use for ADHD. Do they work? Yeah, they work pretty high, way up there, okay? Pretty effective in practice, okay? Pretty effective. So they're gonna have something like 0.9. 0.8, something like using benzodiazepines for panic disorder. Do they work? Yeah, they work for panic disorder. Right around there for an effect size. Not as good as stimulants work for ADHD, but they work pretty darn good, right? Benzos for panic disorder. And then something for the 0.5, well, this you're looking like SSRIs, okay? Depression medications, right around effect size of 0.5. And then when it comes to 0.2, not really having a great impact, meaning, a lot of off-label use, because there's really no medication specifically that are going to treat PTSD in terms of meds per se. So the answer to this question, using medications treating PTSD, would have what expected effect size? A 0.2. Be familiar with this term, and I've neglected it in most of all my other videos. So this is something I really wanted to do for you guys. So be familiar with that. Okay. All right, here we go. It says a new test to diagnose UTIs in women is being assessed. The comparison gold standard is a positive urine dipstick with culture. Results are shown below. Okay, so you're going to see this. What are the chances of not having a UTI when the test is negative? Now, you better hope they ask you biostats questions because you're going to get them all right. Okay, so if they were really nice to you, they would say, what are the chance? What is the sensitivity test? What is the specificity test? What is the positive value? Now, if they would have put that right here, they would have been nice to you. But what did they do? What are the chances of not having a UTI when the test is negative? What are they asking? They just did the definition of what? Of a negative predictive value, right? Test is negative. What are the chances of it actually being a negative test and don't having a UTI? That's what they're asking. So you got to be familiar with this, the 2x2 table, right? Now, and you know this, and I hope you know this. Sensitivity, top left going down, right? Specificity, bottom right going up. Positive predictive value, top left going to the right. Negative predictive value, bottom right going to the left. Now, so if they were to ask me sensitivity, right? Sensitivity kind of rules things out. It was the top left, 40, going down, and whichever boxes I connect by an arrow, I put on the bottom, 40 plus 60. So that'd be 40 over 100, or 40% in sensitivity. If I said specificity, 90 going up, so it's 90 on the, I circled it, goes on the top. boxes I connect are 90 plus 10, that's 100. So that'd be 90%. Specificity is 90%. Rules in. And then we have positive predictive value, negative predictive value. The positive predictive value, top left going to the right, 40 over 40 plus 10. And that's going to be 40 over 50 or 80%. And then negative predictive value, bottom right, going to the left, 90 plus 60. And then, so that's 90 over 150. Cancel out, 3, 5, 60%. Answer choice is going to be, answer choice is going to be B. I almost messed up there. I was looking at my work over here to make sure my math is right, and I circled the wrong one. I apologize. 60%. Negative predictive value, 6%. Now, again, they just did by definition. They could have put just negative predictive value. But again, guys, know the 2x2 table. It's very simple. Once you get it down, you know, again, biostats should never be a weakness on any exam. Any exam. All right, it says, a 10-year study is planned to assess the incidence, okay, that's always the number of new, okay, incidence, N meaning new, of Alzheimer's in 500 individuals over 65 years of age. The study consists of 2 groups, one who lives in assisted living and one that lives at home. At the onset of positive screening by primary care provider, lab work and testing for nutritional deficiencies will be performed. Which of the following best describes this study design? Is it A, case control, B, cohort, C, case series, or D, community survey? Now, guys, you got to go into this exam knowing case control and cohort. Flat out, you got to know it. No ifs, ands, or buts. So the key is at the beginning, ask yourself this, at the beginning of the study, did one group have disease and one not, or did anybody have disease whatsoever? In this situation, they say it's kind of saying one lives in assisted living, one lives at home. Okay, big deal. Does either one of these have the disease yet? The answer is no. One group does not have disease, the other group does not have the disease. And then it says at the onset of disease that they'll do testing. Okay, well that means at the very beginning, nobody had it. So if no group has the disease, this is considered a cohort study, okay? Now, if at the beginning one group has disease and one group does not, then you jump all over case control. But when they both don't have it, you better be thinking a cohort study, okay? Very simple on that one. All right, here we go. You were asked to evaluate the efficacy of a new drug to stop heartburn. The results of the study are shown below. And again, we have, it's a 2x2 table. We got treatment with a new medication, treatment with placebo. No heartburn is 80 people that had the medication. No heartburn was 60 people who took placebo. Not bad, right? Heartburn with the new medication was down to 20, and then heartburn placebo 40, I'm sorry. So with that being said, how many individuals need to be treated to have an impact of preventing heartburn in one individual? What are they asking here? They're asking the number needed to treat. How many individuals need to be treated to have an impact on heartburn in one individual? Number needed to treat. Okay, they could have said how many individuals need to be harmed. Okay, and now I want you to use the same kind of principle on this. But when it comes to number needed to treat, you got to know this formula, right? 1 over the absolute risk reduction. Now, don't get lost in the weeds on this. It's not that bad, okay? One of the very few formulas that you need to remember that at least I would have for the exam. Number needed to treat, 1 over the absolute risk. Now, the absolute risk reduction, I want you to think of it like this. That's just the absolute value of the difference, they say the event rate controlled minus the event rate treatment, vice versa. It doesn't matter. Since it's absolute value, you can't go wrong. It doesn't matter which one you put first because it's the absolute value. It's always going to be a positive number. So think about this. Treatment versus control and treatment. Now, when you treat with a new medication, have an impact of preventing heartburn. No heartburn. So how many people got treated with the new medication? I had 80 here and 20 had heartburn. So I had 100 people there. how many people got treated with placebo? 60 and 40, 100 people there. All right. So we're on the right track. So if I have, how many people got with the new medication, had no heartburn, new medication, no heartburn? It was 80 out of how many? It's not 80 out of 20. It's not 80 out of 200. It's how many people got new medication? 100. How many people had no heartburn? 80. Okay, good. 80 over 100. There's my minus sign. How many, the difference with the placebo? How many people had no heartburn? 60. Out of how many? There was 100 people that got treated with placebo. All right, so 60 out of 100. They're going to have to either give you a chart or they're going to have to tell you these numbers, okay? And so here I am. I'm like 1 over, and this is just some basic math. If I'm going to 80 over 100 minus 60 over 100, that's 20 over 100. And then if I were to, however you learned your math in school, these cancel out, so the denominator is 1, and the top is going to be 5. Okay? Basic math. Know this formula. The number needed to treat is 1 over the absolute risk reduction. Absolute risk reduction is you're just doing the difference between the two groups. Where they're going to get you, where they're going to try to trick you is, a lot of times you're not going to know. They may say N was 200 in the study or something that's going to throw you off. You're not going to know what your denominator is going to be. But it was 80 out of 100 people took the medication. It was 60 out of 100 with the placebo, okay? You got to get that right. So then you'll know that you had to treat 5 people, okay? Know this formula, okay? Know the formula. All right, it says, a new study designed to diagnose Alzheimer's is being evaluated. The sensitivity of the test is 80% and the specificity is 90%. In the study, there are 100 patients who truly have Alzheimer's and 200 who truly do not. How many false positives in the study? Now, you might be thinking, oh my God, they give me this, I'm a dead man. Well, the way I look at it is, if you can guarantee yourself you're going to get a question right on this test, and if there's only 150 questions, man, you need every point you can get. So let's look at this. These aren't that bad. You just have to, what I would do, I would work these out, and then I would screenshot them, and then I would just review them and review them and review them until it, like that. I wouldn't have to rework everything. I'd rework it in my mind, but I would just kind of look at it, and once you get it, don't lose it. Okay? So when in doubt, you draw a 2x2 table. And then the test always goes on the left. Reality always goes on the top. Plus positive, negative. And that just means that in reality, say they did have Alzheimer's, and then reality they did not. How the test says they had Alzheimer's, but then the test said they did not. And then, as they say, the truth is always somewhere in the middle, right? So if the test was positive, and everything is always based on the test when I choose my last name in here. So in reality, they had it, and then test was positive. So if the test was positive and they really had it, well, that is a true positive because everything's based on the test. And then if the test was negative and in reality they didn't have Alzheimer's, then that's a true negative. Okay. So now you got to make sure these boxes are correct. But everything's based on what? Everything's based on the test. So if the test was positive and in reality they don't have it, then that is a false what? Is it a false reality? False test? It's a false test. So it's a false, everything's based on the test. It's a false positive. And then the test was negative, reality they had it, that is going to be a false negative. So you got to get these, you got to have that down. You got to have that down, okay? Very simple. So then it comes down to, they're going to give you the information. Now, you may, do I have to solve everything? No, I would say get focused on what they're asking. How many false positives? Okay, I'm looking for this guy right here. I'm looking for him. So what do I care about? Do I care about sensitivity? No. I do care about specificity because I can use him, right? So that's going to quicken my time. Specificity is what? True negative over true negative plus false positive. So I'm looking for this guy. So now what do they give me? They said specificity is 90%. Okay, specificity is 90%. I don't like percents, I like decimals, okay? Just math. In the study, there are 100 patients who truly have Alzheimer's. So in reality, they truly have it. But that 100 is in this column. It doesn't help me. I want to stay over here. And 200 who truly do not. Okay, well, in reality, there's 200 in this column that truly do not have. So I know that this entire column, or my true negative plus false positive, is 200. Boom, on the bottom. So right now, I can solve for what? I can solve for my true negative. Because all I got to do is, what is, I got to basically multiply both sides by 200. And so 90% of 200 is going to give me a true negative of 180. Now, is that my answer? I should have put that as a distractor right there, right? No, the true negative, the 180 is my true negative. I need false positive. Well, if everybody in this entire column is 200, 180 plus 20 is going to give me my 200. So how many false positives in the study? 20. And again, it's overwhelming at first, but if you have a clear understanding of how you do these boxes, you can zero in. They're always going to give you distractors in here. This is all the information that you needed to solve this question. You hope they give you this one on the test, okay? You hope that they do, because you'll get it right. I guarantee it. And here's our last one, guys. I want to kind of end on this one because you can ask so many different questions on this. It says, a biomarker is being used for detection of a certain disease. 1,000 healthy volunteers with the biomarker are used in the study. Changing the cutoff for the biomarker from point B to point C, so from point B to point C, would likely result in which of the following? Is it A, more true positives? Is it B, increased specificity? Is it C, smaller positive predictive value? Or D, lower false negatives? And again, don't get overwhelmed. This isn't that bad. When you see the kind of a double hump, okay, I just want you to label it first. Now, I was nice. I put these guys came with it, right? So I want you to know this. Here's the very center. And this is the line where we make our money, okay? This is the guy that moves. Whenever they do anything that moves a biomarker, whether it's to the right, to the left, up or down, however they want to word it, you're only moving this. Now, they could give you a question where they didn't give you a picture and they just said that they're going to move a biomarker up, okay? You need to mentally be able to, and I'd practice this. You don't want to do it for the first time. Practice that you can draw this double hump and get it right, okay? And put a line in the center, because that's all you care about. So I guarantee you, they may not give you a picture, and they may say that the cutoff of this test was moved down. It was lowered. It went from 2 to 1.5, and then you have to know that that meant it went here, this way, okay? Very important. I can't stress that enough, okay? Don't overlook that. I'm being nice, right? Because I'm giving you a picture. So, true negative, true positive. They're always on the outside. Everybody keeps their last name. Now, what do I mean by that? I mean, we worry about this center piece. Everybody keeps their last name. So everybody on the right side is going to keep their last name, the positives. He's not a true positive. He's a false positive. Everybody on the left keeps their last name. He's not a true negative in here. He's going to be Mr. False Negative. We work with these centers. Anytime you're moving that biomarker, we work right here, okay? Now, to really kind of master this, now you can memorize it. Yeah, you could. But when you actually get the concept down, guys, I don't care how they ask you these things, and that's where you want to be. You're going to get it right. Again, test is here. Reality is going to be on top. Positive, negative, positive, negative. Okay? So this is going to be my true positive. This is going to be my true negative. Everything's based on the test. So this is going to be a false positive. Everything's based on the test. This is a false negative. Now, I can tell you in these questions, we do not care about him. Okay? We don't care about the guys on the outside. So any question, any answer choice that deals with true positive or true negative, we get rid of it. Okay? Get rid of it. It's just a distractor. It doesn't change when we change these cutoffs. So if we're going to move it from point B to C, B to point C, okay? B to C, what am I doing? I'm taking that line and I'm smashing it this way, right? So I'm smashing who am I making smaller? I'm making Mr. False Positive smaller. I'm moving this line over here. So he gets smaller. Mr. False Negative gets bigger. He gets more space. He gets more space. So if I'm moving it from B to C, what happens? I get my false positives go down. My false negatives went up. Okay? False positives go down in space. False negatives got bigger in space, right? Area under the curve kind of thing. All right? So, now am I lucky with that? Let me see. Lower false negatives. No, I can get rid of that one, right? I can get rid of that one because false negatives actually went up. So now I'm down to increased specificity or smaller predictive value. So, let's look at this. What's my formula for specificity? Specificity would have been bottom right going up. That's true negative over true negative plus false positive. Now false positives go down, and if the denominator goes down, the whole number goes up. So I like that one. I'm liking it right now. Let's just confirm it, right? I like to know when I walk out that I got it right. Smaller positive predictive value. Positive predictive value is top left going to the right. Positive predictive value is going to be true positive over true positive plus false positive, and false positive went down, and if that number goes down, the whole number again goes up, but it says smaller, so it's not him. So again, my correct answer is going to be B. It's going to be increased specificity. So, I've seen where they can say where is sensitivity 0, where is specificity 0. Well, for specificity to be 0, I would say for it to be 1, I guess you could say. I hate to say it like that, but anyways, it's all based on those formulas, guys. If you know this, I promise you, when they move the biomarker, it doesn't matter. Again, you can try to memorize it, but I hate to say you're almost guessing when you can flat out get it right. You got to know this box for the exam. You got to walk in the door with it well under control. So guys, this is where again, it went back to when I was trying to prepare for this for you guys. I looked at this, and I'm hoping that I hit a lot of topics on this. When it comes to mental health, I'll be honest, I'm almost kind of skewed because I look at it like, you learn the disease, you do the medication. Every medication has a side effect per se, or what's the most common side effect. And then you got mental health pretty much down. You just got to get the diagnosis and get them really kind of clarified. Well, what I'd recommend is on this channel, on the YouTube channel, look for the short playlist, and it's Biostats short playlist, and then there's mental health, psychiatry. I forget what I call it. I think it's just USMLE Psych. That playlist, and you can review those. It's very quick. And then you should be able to destroy this exam, especially, it's 1/4 of your exam. You should nail it. So guys, I hope this works well. Maybe one day we'll cross paths. If you have any questions or concerns, you can always try to reach out. I'll do my best to answer them. And good luck on the exam, guys, and give me some feedback. If there's something we can do better for you, just let me know. Take care, guys.